In this final case, we have a patient who presents on the other side of the clinical spectrum of IBS, that is with constipation. As with IBS-D, the presence of abdominal pain leads us to suspect IBS rather than functional constipation or just typical chronic constipation. Remember that constipation is a multi-symptom disorder. In other words, it's not just about stool frequency. I know that as doctors, we tend to focus on how often a person is moving their bowels and use that to define whether they're constipated or not. But realize that many patients that endorse the clinical complaint of constipation actually move their bowels on an everyday or every other day basis, which is normal. It's really other symptoms, things like straining, hard or lumpy stools, incomplete evacuation, a sensation of incomplete evacuation, or a sensation of anorectal blockage that define constipation for some of these individuals. Another thing that patients will tell you if you ask them is some of these patients actually endorse the use of so-called digital maneuvers, that is, actual digital disimpaction, and everybody's aware of that, but also two other digital maneuvers that clinicians need to be aware of. One is pressing around the anus to facilitate defecation, and vaginal splinting in women, which is a pretty clear sign that a woman has a significant rectocele. So those digital maneuvers, we'll talk about in just a moment, have some predictive value in identifying patients with so-called outlet obstruction constipation. Remember that not a lot of testing is needed to identify patients with IBS-C. Certainly, routine colorectal cancer screening is always indicated in everybody, and patients with symptoms suggestive of IBS-C are no different. So if a person's over the age of 50 and has never had a colonoscopy, they should absolutely have a colonoscopy. On the other hand, if a 29-year-old comes in with constipation, particularly if it's mild to moderate in severity, you probably don't need to do a colonoscopy unless they have so-called warning signs or alarm features. More on that in a moment. In this case, the patient did report an important warning sign, that is blood with her stool. Rectal bleeding is a warning sign or alarm feature. That is, it's a clinical feature that's thought to increase the likelihood of an organic diagnosis, like colon cancer or inflammatory bowel disease, for example. There are obviously differences between patients who report a little spotting on the toilet tissue after a bowel movement and those that have true or frank rectal bleeding. For example, painless spotting of small amounts of blood on the toilet tissue after a bowel movement usually is a sign of hemorrhoids. On the other hand, patients that describe painful defecation, and often, with or without bleeding, you should be thinking about an anal fissure, which can occur in patients with really hard or lumpy stools or excessive straining, by the way. So bottom line here is that you need to take a careful history, as we've talked about the multi-symptoms that define constipation. You need to assess specifically for warning signs or alarm features like rectal bleeding, weight loss, a family history of important organic diseases like colon cancer, inflammatory bowel disease. And you need to do a careful physical examination, not just of the abdomen, but also perianal inspection, as well as a digital rectal examination. It's very important to do those things in patients that you see with the clinical complaint of constipation. Relevant to colonoscopy, remember that if a patient has warning signs or alarm features, you're going to want to do a colonoscopy even before that age of 50 that we typically recommend a colonoscopy for the purposes of colorectal cancer screening. One thing to say about this population, though, that I see in my referral practice oftentimes is patients that come in with complaints of constipation that have multiple colonoscopies. You could make the argument that one colonoscopy is very reasonable, but if a person has a high-quality colonoscopy with an adequate preparation, they don't need repeated colonoscopies. It's not going to do anything to help in making your diagnosis, and it's not going to help the patient to get better. Now, dysenergic defecation is a condition where patients are unable to coordinate the series of activities and events that affect the anorectum and abdominal wall musculature that allows them to evacuate stool from the rectum. So remember that to normally evacuate stool from the rectum, one needs to contract their abdominal wall musculature. This increases intrarectal pressure. Now, concurrently, there needs to be relaxation of the puborectalis muscle, a muscular sling that goes around the distal portion of the rectum and creates an angulation that is an important continence mechanism. Relaxation of the puborectalis allows straightening of that anorectal angle. And then finally, there needs to be relaxation of the anal sphincter. So you need to have contraction of the abdominal wall musculature, relaxation of the puborectalis, straightening of the anorectal angle, and relaxation of the anal sphincter to be able to normally defecate. If one or more of those things goes awry, patients can't normally defecate, and that is so-called dysenergic defecation. Now, why am I spending so much time telling you about this? The reason for that is because patients with dysenergic defecation typically don't improve with laxative therapy. So, a really important clinical pearl for all of you listening in the audience today is that patients with constipation who don't respond to over-the-counter or prescription laxative therapies are enriched for dysenergic defecation. And these are precisely the patients that need to be referred to a gastroenterologist for detailed physiological testing, and if dysenergia is found, referred to a physical therapist for physical therapy and biofeedback training, which is the optimal therapy for dysenergic defecation. Remember as well that patients that don't get better with laxative therapy are also enriched for other forms of outlet obstruction constipation. So not just dysenergic defecation, but also mechanical causes of distal rectal obstruction. So things like intussusception, rectal prolapse, enteroceles, and rectoceles are all more common in populations of patients who are not responding to laxative therapy. So take-home message for everybody in the audience. There are a number of different over-the-counter and prescription medications which can be highly effective. If you're going to use over-the-counter and prescription medications, remember to give patients specific advice in regards to how to start and how to titrate up the therapy to optimize response. And that's true for fiber supplements as well as osmotic laxatives, stimulant laxatives, and the prescription medications, which now come in 2 or 3 different doses, depending on which medication you're talking about. If an individual doesn't respond to over-the-counter or prescription laxatives, those are individuals that need to be referred to a gastroenterologist for physiologic testing. Obviously, if a patient has so-called warning signs or alarm features, they should be referred to a gastroenterologist for more detailed structural evaluation with colonoscopy, for example. Patients that don't respond to laxatives are more likely to have any of a number of different causes of outlet obstruction constipation that are treated with either biofeedback training and physical therapy or surgical therapies if there are one of those problems that lead to mechanical obstruction. So hopefully you found those comments helpful in terms of managing your patients with chronic constipation.